heart rate, and oxygen saturation. AI-powered insights. Detect potential health risks through advanced AI and machine learning technology. Convenience. Perform regular scans from the comfort of your home using just your smartphone. How it works? Getting started with AgeWiser Vitals is simple. Open the Vitals menu. Navigate to the Vitals section within the AgeWiser app. Take a quick scan. Use your phone's front camera for a short scan. Get your report. The app analyzes the video using RPB technology and generates a report of your vital signs. Monitor regularly. Perform regular scans to track trends and identify any changes. User testimonials. Here's what our users are saying about AgeWiser Vitals. Additional tricks. Here are some tips for maximizing your experience with AgeWiser Vitals. Well-lit area. Stand in a well-lit area for optimal scan accuracy. Proper positioning. Ensure your face is centered in the camera frame for best results. Regular monitoring. Conduct regular scans to track trends and identify any changes in your vital signs. Ready to monitor your health effortlessly? Don't wait. Take control of your health with AgeWiser Vitals. Open the Vitals section in our app today and experience the convenience and accuracy of remote vital sign monitoring. Download AgeWiser today.
We all know someone with dementia. It's on the rise.
Older adults are very concerned about their brain health. Nobody wants their bodies to outlast their minds.
None of us want to lose our minds, and there isn't a convenient place to go to address these concerns. There are no brain gyms. Until now.
To put it simply, Marbles is your brain gym for cognitive health.
So this is the first of its kind gym.
Marbles wants to give people affordable access to the best technologies to stave off dementia.
When you're doing these cognitive games, you're engaged and you're challenged and you're making mistakes and you're laughing, but you're also moving at the same time.
And it requires some work, but it allows them to succeed just often enough to satisfy their preferences. So Marbles is never going to be harder than you need it, never harder than you're capable of, but just powerful enough to stimulate connections in the brain, neuroplasticity.
So the big inspiration is to make these technologies available, accessible, affordable to the public to help prevent the onset of cognitive decline. Franchising is the fastest way to get it to the public.
There are many reasons why this is such an amazing business opportunity for potential franchisees.
We've designed Marbles to be a low entry price, low overhead, affordable to the customer, and extremely simple to operate.
That's why I'm here as the medical director for Marbles to design the programs, to identify the equipment, and to help you achieve your optimum in brain health.
You know, there are a lot of franchise models out there, but this is really a one of a kind.
Marbles is basically my what was I made for moment.
We all know that physical exercise is good for the brain and mental exercises are good for the brain, but when you combine them at the same time, that is the holy grail to keeping your marbles.
HelloNote is a truly therapist-friendly practice management solution with integrated EMR that will enhance workflow, efficiency, and patient care. HelloNote reduces error and allows you to spend more time with your patients. It comes integrated with billing. Claims are generated once a note is completed. You can bill with one click and a patient portal, which streamlines the patient intake process. Beautifully engineered and cloud-based for easy accessibility, the software works on all platforms. You can access patient records from anywhere. We also offer 24/7 support. HelloNote is the practice management solution that you're looking for.
All right, guys, get ready for our next speakers. So I hope you had a good break, a little bit of dinner and a breakfast. All right. So thank you once again, Dr. Erica, for that wonderful lecture. And we would love to thank as well our sponsors. We have wonderful sponsors that were able to help us and support us to deliver affordable courses or webinars, wonderful lectures, and then also able to support our other beneficiaries. We have some students that were able to attend for free, and also this will be affordable rate for us physical therapists. So we have another sponsors, the Maradigm Live. LIV is like a low intensity vibration device that safely improves muscle strength, functions, and circulation. This is really good because it is like, I saw it, it's like a weighing scale, but there's a function on it, and we will learn more as we goes with our summit. So this is more than like the result from 30 years of basic and clinical research funded by the National Institute of Health and National Aeronautics and Space Administration. Imagine that. So thus conditions such as rebuilding muscle mass, restoring joints, adjunctive treatment for obesity. So these are really good. So that's the low intensity vibration. And we talk about Parkinson's disease for some of you who wants to learn more about improving your credentials, learn about the high intensity amplitude exercises, check out LSVT. LSVT are for physical therapies, occupational therapies. We even have, that's the LSVT big. So the LSVT loud will be for our speech therapists. So these are very good, and this trains neurological disorders. So this is not only for Parkinson's disease, but they cater more on the Parkinson's, but they have now more evidence that they can also help multiple sclerosis and other neurological disorders, you know. So LSVT big trains people with Parkinson's disease and other to improve large motor tasks, things like that. All right. So we'll learn more about that. We have Dr. Laura Gusset tomorrow. And that's our break for today. And these are our amazing sponsors. We even have, I put the Future Foundation here as we would love to offer part of the proceeds. And it is a nonprofit organization that I am part of. And it's originally from my alma mater and things like that. But we have a wonderful mission and vision that we support our organizations as well. And also we have 2 scholars now for DPT. And these are some of the sponsors, supporters that always helps us whenever we have once a year. We only do this once a year. So guys, thank you for your support. And we learn about Marbles Brain Body Fitness, the only fitness gyms focusing on brain and body. That's wonderful videos that. So now we have our next speaker. We only have 2 speakers left. And then we have Dr. George Rodriguera, and we will going to discuss about force progression in manual physical therapy. So who is Dr. George? Look at his credentials. Amazing. He's a physical therapist and doctor of physical therapist. And we worked together at one point when I was new in home health. So he's really amazing physical therapist. And then I met his wife as well, wonderful family man. So Dr. George Rodriguera finished his bachelor's degree in physical therapy from the Philippines in 2002. He migrated to US in 2008, and in 2014, he finished his doctorate of physical therapy degree from the University of Montana. Then he continued to Master of Science degree in Orthopedic Manual Physical Therapy from Damon University in New York. Since being in the US from 2008, Dr. George has been a physical therapist in the outpatient clinic setting. He had acute care, rehab centers, long-term care facilities, and work in home care. Dr. George has certification and specialization in Mackenzie method of treatment, orthopedic manual physical therapy, kinesiotaping, dry needling, and is a certified clinical instructor as well. He is a member of the American Physical Therapy Association and a fellow with the American Academy of Orthopedic Manual PT. Dr. George loved to spend time with his son, George Vincent, and when he has a weekend to spare, he play table tennis. All right, Dr. George, thank you so much for this opportunity. We would love to get some of your brain about manual physical therapy. We have a fellow in the house, so we'll get to you, Dr. George. Welcome.
Thank you. Thank you for the very warm introduction. I'm laughing over here because my family around me is laughing at me too because of that warm 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 introduction. Thank you very much.
You're
And
welcome,
I'm
Dr. George.
happy to be here. Thanks for the invite.
Yes, yes. My
All
pleasure.
right. Let me go ahead and share my screen. And thank you to the earlier presenters. I learned a lot. How do I do this again? Share. All right. I learned a lot from everybody earlier, and I'm going to steal some of their pearls today. Just by listening, I have some pearls that we can use and apply through this presentation. So let me see if my things are working. All right. Can you see my screen okay?
You can make it full screen, Dr. George. That's the
Right.
only one missing. Yes, all good. Thank.
All right. So it's working good. So again, my name is George. Thanks for the introduction once again. So all those certifications are part of the journey of manual physical therapy. Um, it's an awesome investment to have. I think the one of the best investments I've did with my professional life is through that fellowship program, because it gave me a mentor. It gave me a path to understanding what outpatient physical therapy is for me and to my practice. Now we have an outpatient physical therapy here in Delaware, and me and my wife we're managing it, and we're applying all this knowledge that we got to our patients, and we have we have successes and we have some disappointments too. There's still a lot to learn with orthopedic or manual physical therapy. Now I always ask myself through this journey, who do I learn it from, and then what else is there to learn outside? Now, what I chose to do, and I encourage to do the same, is when you find something that you like, and if they have a series of lectures or a series of seminars, you go through them. You go through the series and you understand better the system. I like to share with you that most of the series of courses, like manual therapy with Maitland, Mackenzie Institute, for seminars, they 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 are popular with some stuff like joint mobilization or repeated movements, repeated extension, prone press ups, and all that. But what they really teach throughout the program is not just the techniques, but also the assessment process. That's what I got from the series of courses that we went through and that was mentioned, is that there's a systematic way to assess and evaluate patients so that you can use the techniques that they teach to be more intentional. Okay, so there's a lot of tools in the toolbox. For example, there's Maitland techniques, Mackenzie, mobilization with movement. You learn from other courses, dry needling. Now, through our assessment to the patients, we are guided by an assessment process on which technique from the toolbox is most appropriate. Okay, so with all these techniques that we learn here and there, one of our best teachers that would teach us actually is the one that we work with every day, our patients. Believe it or not, with exercises, with manual therapy, if we listen and if we ask the right questions, we would know what they want, how much exercise they want, how much manual therapy they want, even what technique to use. and in what load and how much. I'll tell you what I mean later, and that's the real uh, purpose of this presentation is progression and or regression of manual therapy. Because again, based on the patient response, based on what the patients tell us, as I said, they're the best teachers that we can have. And through experience, we could be more intentional with our treatment approach based on all that collective experience that we gain from our teachers, which is our patients. All right, so the objectives are utilize patient response method. You know, those techniques that we mentioned, Maitland, Mulligan, Sarman approach, McKenzie approach, they are patient response method. Okay, so we will learn how to utilize those in a day-to-day basis in the clinic. Okay, and now I want to modify this force progression and force alternatives. Now it's also force regression if we need to, and I'll tell you what I mean later. So it's going to be understanding force progression and or regression as needed, and force alternatives in using manual physical therapy. Okay. Now, these are examples of manual physical therapy. You know, there's a lot of techniques you can facilitate. You could use tools, you could use your hands, you could tape, you could massage, you could mobilize. And this guy over here in the bottom, who's really sad because he has needles in his face, would be myself. And when I took my my dry needling course. Okay. Now, all right. So what is manual physical therapy? We have options, as the pictures mentioned earlier. Now, talking about manual physical therapy online is very challenging. So today we are focused on the theories behind it, maybe some rationalization on what to do, how to do it, and why we're doing it. Okay. So different types of manual physical therapy would be, I'm a fan of this one. This is the simplest one, passive range of motion. Passive range of motion, we do bigger movements, passive physiologic motion, depending on what language you use. But it is passive range of motion. Is very helpful for patients. Soft tissue based, nerve bias, manual physical therapy, and mobilization with active movements. Those are options. And on the side, there's goals that we can use them from, you know, to regain extensibility, mobility of the joint or soft tissues, pain relief, and improve fear avoidance. Okay. The main question is, which one do we use? Now, the list is many, and what we're going to talk about today is joint mobilizations. Okay, so the other stuff we have to pass on for next lectures. Okay, so we're going to talk about joint mobilization. Okay, so before we could talk about joint mobilization, we have to talk about the mechanisms. All right, earlier, Mr. Evan talked about there's natural chemicals in our body that creates painkillers, right? Endorphins. Now, and there's a lot of studies about that. That's what you call neurophysiological effects of manual physical therapy. So it's one of those wonders of our body that it heals itself. And our job as physical therapists is to enhance and improve that healing. So these are chemicals that are produced in our body. It was well discussed with Mr. Evan earlier. And the other one is biomechanical effects. So think about this, guys. When we mobilize a shoulder, for example, we put it on resting position, we touch the patient, right? So the first contact there is the skin. There's warmth, there's you know, sensitivity of the skin, or it feels good or it feels harmful. Either way, we influence that perception. Now, the next one is fascia. So when we press a little harder, there's soft tissue, there's joint capsule, and there's joints. Now, if we do what we chose to do as joint mobilization, for example, if you caused relief, do we exactly know what is the mechanism of that relief? Did it get better with the joint mobilization? Was it influenced by the fascial aspect of pain, or soft tissues, or the muscles around it, or just the warmth of our hands? You know, those are neurophysiological effects that is always a wonder for me, because it's all pain generating structures. All of them can cause pain, right? But our intent is to mobilize the joint, improve range of motion, decrease pain. Now, the mechanism behind that relief is really questionable. Is it biomechanical or neurophysiologic? So these are the studies. I'm not going to read through all of them. The reference will be below, but these are studies now of modern pain mechanism and manual therapy, as far as chemicals in our body being released. Okay, and earlier is cortisol levels were discussed, and again, all these chemicals in our body are being released every time we do manual mobilizations and exercise. Now, thanks to Dr. Morris earlier, our keynote, I don't have to explain clinical practice guidelines as much, but it is the top of the pyramid, as he said. Now, this the clinical practice guidelines for lower back pain, and it is similar for neck pains. It's similar for other structures. It may be different from A to B or to C level of evidence based on the available evidence, but with lower back pain, for example, it's pretty high. So manual physical therapy and thrust and non-thrust mobilizations are rated A to B. Now, there's a question earlier, a couple hours ago, with dry needling. It is there. It's level C right now. But again, remember, this is based on evidence. Maybe for CPGs, it's 5 years or more back. So new studies will come, and maybe all of these would change in the next time they change it. Okay, so, but currently, as far as the CPG, as far as our recipe is concerned, there's high evidence for manual physical therapies for acute and chronic lower back pain. All right. Okay. Now, joint mobilizations and manual physical therapy, I can't not discuss contraindications. Now, this is relative contraindications, because we can do manual physical therapies, but you have to run down through that list of options, you know, soft tissue, nerve glides, mobilization with movement. You have to run through the list of options to decide what kind of manual therapy you're going to use. So these are relative contraindications. Now, what is very important is the contraindications. Now, these are the ones that we should not miss. Okay, very important. The red flag questions we have to always ask. I always say, and the ones that are not here too, if symptoms doesn't add up, you know, if they're coming with lower back pain diagnoses and they're walking funny, it doesn't add up. So you have to ask questions, you know, if there's generalized neural signs, tingling, numbness here, increase reflexes, you know, spasticity. And I have patients that come in for back pain and walking funny with a foot drop that wasn't diagnosed. So it's those things that we assess are very important. Again, if you even ask questions and it doesn't make sense, then it might be something interesting to look at. Okay, so check for contraindications, make sure you're safe and covered. All right. So this is what I was talking about earlier. I'm a fan of passive movements. I'm a manual therapist. So it's either passive physiologic or passive accessory. Passive physiologic is just another term for passive range of motion. It's a long lever arm versus passive accessory movement, which is a shorter lever arm, right? So it's those anterior, posterior, inferior glides. So that's options, right? We're talking about manual physical therapy now with joint mobilizations and joint mobility. So now you have options. I am a fan of combining both. There's evidence by Edwards there that passive physiologic and passive accessory is a valuable combined intervention. Okay, so that's, and I mean, we do this every day anyway, but somebody was smart enough to do all the work and get credits for it. But we do it every day. We do mobilization, we do passive range of motion. It's almost intuitive. Now, also we have a question of thrust or non-thrust techniques. Thrust would be grade 5s. We'll watch a video on that in a little bit. Grade 5s and non-thrust techniques will be grades 1s to 4s. And this is just a review for everybody. I just have to run through it. Now, thrust techniques, we definitely have to practice and train for it. If anything, this is what's sought after a lot of times for courses, because this is the skill, and the repetition needs to be there, and the confidence. And I'll share with you some contraindications of thrust and non-thrust techniques in a little bit as well. Okay, so these are options. Now, what's good about us is we have options. We have a toolbox, and it's our job to choose what is best for our patient at that particular time. And sometimes that need changes from day to day. One day they need passive range of motion. One day they need passive accessory motion. So it changes, and it's within our scope to make decisions for a patient, whatever is appropriate for them. All right, thrust versus non-thrust, and there is evidence for both. You have, I call them thrusters. You have evidence for thrusts for a lot of patients, and they have a long list of references too. Now, non-thrusters would have evidence too. They would say long-term and short-term effects, and in the long run, they're both the same, stuff like that. Now, I always tell everybody the only time in my practice anyway, I don't want to say the only, one of the top reasons why I would thrust on the first day is, number one, is if the patient is asking for it. If they have a story, last time when I went to a physical therapist, they cracked my neck and I got better right away. So the perception is there. So you have options then. It's either you do the thrust because the patient is asking for it and there's an inherent preconception about the results, or you want to educate the patient now, about thrust and non-thrust and the studies behind them. It's a decision. Multiple times in a therapy visit, we make decisions for a patient that is again multiple, how to stretch, how much, how many sets. Can you imagine how many decisions we have to make within that hour session? But anyway, so with thrust and non-thrust, there is an inherent placebo effect, which is a positive reaction to it, or a nocebo effect, which is a negative response or negative conception about it. So we have to talk to our patients. We have to evaluate what their preconception is, and then it has to be in our decision-making process whether we do thrust or non-thrust techniques if we choose to do joint mobilizations. Okay, so dose, I have a running joke when I do courses, it's an 8-minute rule. So we have to at least do 8 minutes to be paid, right? Outpatient people. So if it's 8 minutes, then we're good, and that's our dose. Now, what is the real answer to that question of how long do you do manual therapy is, regardless of insurances, and I have a whole gamut of spiel with insurances because of being private practice. So those of you who are in private practice, you know what I mean. But with dosage, now the real answer to that dosage, to how much, is however much the patient needs until you get your desired effect, right? So it's very vague, which is it's the best answer I could give you. So the amount of physical therapy you give each session is based on what your goals are for that session. Okay, does that make sense? So if your goal is to improve flexion, for example, if your goal is to improve flexion, now what a good manual therapy session would look like is that you assess your range of motion. You said, oh, it's 130 degrees, for example, of flexion. Okay, you choose a range of motion. Then, as I said earlier, you gather your toolbox and see what options you have, and then it's your decision on what mobilization to get. In, again, a decent manual physical therapy session, I would suggest that we choose one or two techniques. One is good, two is max techniques with that session, and then recheck your baseline. So you check range of motion flexion 120 degrees, 130 degrees, for example, 130 degrees. Now, we do our technique, whatever technique it is. It's not in the scope of this session, what glide you'll use, or what, if you do passive range of motion, that's fine too. So you do your technique, and then after 8 minutes, no, not 8 minutes, after your desired, now on my rule of thumb is 100 bouts, 3 sets of 100 bouts. That's my rep. Okay, does that make sense? So 100, if it's oscillatory, it's 100 bouts, pause, and 3 sets of them. And that's my one rep. Now I do 3 of them, and then I check my baseline. All right. So I don't know how long would that take, depending on the patient. You're talking, you're not talking. Irritability is very big, which we will discuss in a little bit. Now, so that's my set. And after my chosen technique, one technique, or maybe 2, and I'll have the patient retest the way I tested the first time to be consistent, and check range of motion again. Now, if my goal was either decrease pain, then I'm going to ask for pain levels before. If my goal is to increase range of motion, then I'm going to check from 130, did it increase or decrease? And again, sometimes it will decrease. As I said, the patients are our best instructors. So if it decreases, then we have other options and decisions to make, right? So if we have, so that's a decent picture of a manual physical therapy session. Baseline, do your mobs, and recheck. All right, and hopefully that would be in 8 minutes, all of them. A baseline, manual, and recheck. That's included in your one unit. And I'm laughing again because I'm imagining my students. But that's included in your 1 unit of physical therapy. Now, if you want to do more, you can do more based on, and it depends on what your goals are at that particular moment. Okay, so irritability is a thing. Now, irritability is defined as how much force can create how much symptoms, pain or stiffness or range of motion, and for how long. Okay, so irritability is how irritable the patient is, how sensitive the patient is at that particular session, before you do your manual physical therapy. So again, how much force produces how much symptoms, and if it comes, how long does it last? And remember that, because we will talk about that in depth in a little bit. Okay, we will talk about irritability a lot today. All right. Okay. Now I'm just checking my time because I can talk. All right. Factors related to those, we've been talking about this. The amount of stretch, irritability is number 2 in that list. Choice of a passive accessory or passive physiologic. This is those for joint mobilizations, or choice. The non-thrusts can be oscillatory or static. Okay, and you know what that means. It could be oscillating, or you could press longer, slower. Okay, now, so the length of time, and then choice of thrust and non-thrust techniques. So these are the factors that affect your dose. So when you choose among the list of manual physical therapy, if you chose joint mobilizations, then these are your decisions. See how many decisions we have to make? There's at least 6. I think I'm missing something there, but when I was making this slide, I got 6 decisions to make just for that 8 minutes of treatment. Okay. All right. So I'm gonna share this for you. I have this. Just to example, let's take a break and then let's just watch this.
But what I
Please
want to
tell
talk
me,
about today
please tell me if you can hear the audio, okay?
is joint mobilizations, more specifically grading of joint mobilizations.
Yeah, this video is
All right.
old.
So traditionally, we have grade 1s, 2s, 3, 4s, and 5s. In school, we were taught grade 1s and
You can hear the video, okay?
Yes.
2s are used to decrease pain, and 3s and 4s and 5s are used to improve range of motion. All right, so it would look like this. So for whatever reason you choose a joint that you want to mobilize, and you just use the grading that we would think that's appropriate for the patient's goals. All right, so you choose a joint. In this case, it's a lumbar spine. I would say I'm an L4, and I would just do grade 1s. So grade 1s would be small amplitude oscillations. So grade 1 is before any tissue resistance. So it's very light. The only difference with grade 1s and 2s, they're both before tissue resistance, but grade 2 would be large amplitude. So it's a little deeper, it's still before tissue resistance.
Let me pause this real quick. So I must, I want to emphasize, again, we're not in a live course, but I want to emphasize the form. When you do oscillatory, either it is peripheral or spinal, your target tissue should be way under you. And Maitland techniques and Maitland tests would say your nose has to drip onto the area that you're mobilizing. Okay, so elbow straight, the table in this case needs to be lower so that you could definitely go over that patient.
Okay, now grade 3 will be another large amplitude. This is into tissue resistance, and traditionally it starts at 50%. Okay, grade 4s would be the same amount of 50% resistance, or starts at 50% resistance, but large amplitude. I'm sorry, that's small amplitude. Okay, so that's grade 4. That'll be my grade 4. All right, that's typical.
So I'm going to correct myself there with later with the grading of mobilization, I'll show you a slide where about the 50%. All right, so as far as mobilization, I teach this live in courses here in Delaware. Now, again, options for us, So when you say unilateral posterior to anterior, now let's just say that the first picture, the first picture on the left is I don't know, L4 transverse process, for example, right side. Now that's a straight UPA. Now when we do mobilization, what we need to look for is a comparable sign. It's great, and I love it when the patient tell me this is where my pain is. It's just one finger or two, maybe three. That would be good, you know, like a small area to work with, so I can look for them. If it's pain across the lower back, then it's a lot more work, right? So because you're looking for the patient's symptoms. Now looking for the patient's symptoms might mean changing the angle, which is what it is on the right side. You know, if you need to change the angle on a 45 degrees caudally, 45 degrees medially, if you're looking for that patient's symptoms and you talk to the patients, you know, is this close to where your pain is? And they'll guide you, you know, a little to the left, a little to the right, and stuff like that. And that's that's how you position your fingers in. Now that's all part of the decision making. You can't just do straight anterior, and just because it's straight anterior, the way they were taught, then you stay there. You change your angle based on what your patients are needing at that particular time. And with mobilizations, we can mobilize in neutral, in extended, and in an extended position. You could mobilize, as you know, we could mobilize with movement. While they're moving, we could continue with a static pressure in the spine. So there's a lot of options here, depending on what the patients need. And again, we'll talk more about that in a summarized slide later. All right. So these are options. I want us to realize that there's options to be thought about when we do mobilizations. Whether to do, for example, the first one is neutral and mid ranges. Now you can mobilize in a full extension, which with a full press up, if the patient needs that, and if the patient is very flexible and still needing extension. Okay. Now, this is another example. You know, this is in this position on my left. This is a unilateral posterior to anterior on an angle. So if the patients need that angle, I think I emphasize that today because that's what a lot of patients are missing. So find your angle, find your comparable signs. It doesn't always have to be straight. Okay. Now, in this position, my right hand, on the middle picture, my right hand is doing a glide at the end of that side bending. All right. So this can be a common position for patients needing side bending. It's either I do a passive range of motion, or I do a transverse glide with my right hand, or I do both. Options are unlimited. Now this one too on the right is passive range of motion of rotation. It's unloaded. We could do it in sitting, and you could do it in lying down, which is the picture. Now, sitting is very, very beneficial because it has that load. And when we sit and when we lie down is another decision to make. Okay, so I could do a passive range of motion, or I could do a passive accessory motion with my left hand to do a posterior to anterior glide on wherever my thrusting knuckle is. You know, as you know, these are premanipulative. We could do grade 1s to 5 in both of these positions. All right. So these are grade 5 mobilizations. You know, what role is this on the right, if anybody knows? Flynn et al.'s clinical prediction rule for lumbar mobilization used that role, Chicago role. And but it was lumbar mobilization, but interestingly enough, it is an SI joint mobilization. But with that clinical prediction rule, this was the one that they used. But anyway, that's a different topic on its own. Now, this grade 5 mobilizations on the lumbar spine is that. So Now, to go here is a progression on its own. Now, again, the question is, do you start with this positions or treatments, or you do lower grades first? So again, that's the decision that we have to make. All right. So same things with this mobilizations. It's just different angles. You know, seeing this picture doesn't always have to be grade 5s. I could be doing, this is CT junction, a popular CT junction on the right. Without knowing where my right hand is, it could be C7, C6 with side bending. And I could be doing grade 1s and 2s or grade 3s and 4s in this position, depending on what my goals are. It doesn't mean patient is in that position that I'm going to thrust right away. Does that make sense? Because those are options. You can do lower grades in a manipulative position. I think that's not stressed enough in any course. Again, you in a manipulative position, you can do grade 3s and 4s there in that combined position. This is a combined position of side bending, rotation, and extension. So it's very powerful technique, guys. So if you try this on Monday, if you are not comfortable, one of contraindication of grade 5 is the clinician is not comfortable doing it. You shouldn't do it. Okay. But if you are not comfortable, you shouldn't stop there. You can do a grade 3s and 4s in a manipulative position, and it could be as powerful. That's why they say non-thrust and thrust would have the same benefits if you apply that position. Does that make sense? It's just not that quick thrust that we're looking for. All right. So think about that. So this is Maitland grading. All right. So I mentioned earlier the 50%, 3s and 4s. Now, the R1 here is tissue resistance. 1s and 2s is before tissue resistance. Once you pass tissue resistance, you're doing 3s and 4s already based on your number of amplitude. Okay, let's say that again. So 1s and 2s are before tissue resistance. All right. Once you pass tissue resistance, you're doing 3s and 4s right away. I tell this to my students all the time, is that once you pass tissue resistance, you're doing 3s and 4s. Now think about it. How many times have you passed tissue resistance and still graded 1s and 2s? You know how light that 1 and 2 is to be defined as before tissue resistance. That's very light. Okay. And again, if we were in live class, we'll practice this to be as light as you can for 1s and 2s. And then, you know, that 25%, that 50%, and 75%. And this is being tested. Is it a time issue? Okay. It's being tested with when you do Maitland testing. Okay. I'm not going to spend a lot of time on that. So these are contraindications of grade 5. Again, we have to talk about it. It needs to be important. We need to look for them. Okay. I'm not gonna run through it. And again, the important thing there, practitioners, letter G, lack of ability. You shouldn't do grade 5s. You have to practice. You go to courses, practice among your peers. But again, you can do lower grades on a pre-manipulative hold position, and you should, especially if it's older and you don't want to do a thrust. You should, and that's for extremities, spine, and everything. Okay. All right. So grade 5, and we know this already. So grade 5 mobilizations, we are not putting things together. You know, we're not, what do you call that? Adjusting anything or putting it back into place. You know, we're not doing that. It's gas, it pops up, it frees up the joint, and it improves range of motion. Okay. And I don't want to say it doesn't happen, but in this study, 2% has issues with cervical mobilizations or manipulations with vertebral artery issues. Okay. It's not to say that it doesn't happen, but it's very low, provided, and again, it's beyond the scope of this course, but provided that you do due diligence to check your ligament test, upper cervical stuff, upper cervical ligament tests, okay? All right, so I was gonna show you some, just one maybe. I was gonna show you some motions. This is in, so, oh, I actually don't know how to go back. First one. See, I haven't been in my channel that I don't know. So maybe this one. So CT junction. This is an old video, guys. Pardon the old video. So it's CT junction. So let's watch that again, okay, real quick. Okay, all right. So again, in this position, I can choose to do a passive range of motion with my left hand, or I could do a transverse glide with my right hand doing lower grades. I do not have to thrust here in this position, okay? I need you guys to try that this weekend and send me a message if it worked or didn't work. But check your baseline before and after, if it's neck or lower back. You know, you could do a premanipulative position and mobilize there. So I didn't have to thrust there, but that was a thrust video. All right, now I do have more thrust videos in my very old channel. That's a very old video. That shirt doesn't fit anymore. Okay, so again, imagine what would a therapy session look like. Check your baselines, have a goal in your mind, do your MOBs, and then check again. Okay, so short-term changes, there are evidence. I need Miss Jen, I need to remind me of the time, please. Okay, because I can talk. Now, all right, short-term changes, immediate effects. Now, if you have, and you imagine that session, right? Check, treat, and then check again. Now, if you have a gain in range of motion, it tells you a couple of things. More importantly, it tells the patient that you know what you're doing. You're increasing your range. That's great. Secondly, it tells you that you did it correctly. And in your mind, you rationalize, this is the tool, this is the option, this is the decision, this is what I'm doing. One technique. And you increase your range of motion. It gives you confidence. It gives your patient confidence on you. So it's a win-win. So that's why I would like you and ask that you do that way to give you confidence and give your patient confidence on you. And that's big. Once you'll see it when you do it and you see that patient reaction, when they gain range, and that's magic. That's magic right there. Their eyes would light up and they'll nod, and then they'll just, say praises. Now, it's a short-term change for manual therapy is very well known. Now, the long change is questionable. What this next study says is early and continued change. So if you change every visit, then the long term would automatically be better. And it's a predictive outcome. So it means that if you chose a mobilization and you have immediate change, it means that your prognosis just got exponentially better. All right, makes sense? All right, next slide. Please tell me if I'm talking too fast, okay? I'm just running out of time.
So Dr. George, so you have 5 minutes lecture. You can save like 5 minutes QA too.
Okay, all right, so here you go. So patient response method is what we use. That's the patient response method right there. Check, mobilize, and recheck. All right, that's just listening to your patients on what they want, what they need, and how they respond to what you're doing as far as manual therapy. Okay, communication. And I'm going to steal Dr. Morris's traffic light guide there. Thank you, Dr. Morris. All right, another stolen traffic light. I make sure, Dr. Morris, that your traffic light is complete. Okay, I'll return it to you. All right, now traffic light guide. Okay, if anything, Q&A might be delayed, but if anything, the next two slides is very important. If anything, If anything you learn from here, use this stolen traffic light in the next slide. This is traffic light guide, like Dr. Morris said. Now, if you do a manual therapy and it got better, 130 degrees, 160 degrees, pat yourself in the back. So it means it's a go. It's either you do more or you stop there, it's a green light. You do it next time again. The second scenario there is you chose your mob. When you check again, it didn't change. No change. Not worse, not better. It didn't change. Options: do it again, do a higher grade, or change your direction. Okay, change your technique. Okay, those are options. Now, red is stop. You made your pain worse, peripheralized symptoms if it's cervical, and then you assess irritability, and then you assess how long. Remember, irritability is how much force, how much pain, and how long does it last. Now, if within that session the pain went away, it might be a yellow. All right. Okay. Next slide. Sorry, I'm running out of time. Now, treatment progression and regression. Now, it's very light. I'm sorry about that slide. Okay, let's do it again. Patient-generated force, for example. So patient-generated force is just active exercises, okay? We are at clinician-generated force, and then we are graded force progression, which is grade 1 to 5. Now, options, sagittal, right? So sagittal is multiplanal movement. Now, if you have bilateral pain, cervical, spine, and even in the shoulder, you could apply this. If you have sagittal forces, meaning straight PAAPs, then you can do, if it's a yellow light, you can do lateral forces as a progression. Okay, so think about that. All right. Now, options again, if it's a yellow light is the best light ever. Okay, because you have options in your brains will start thinking, and you could think of options. Do I increase reps? Do I use sustained? Do I unload? Remember earlier, the CT junction was lying down, and you have a CT junction seated. Now, loaded and unload, you choose. Unload is less force in the joint. Now, if you have a patient, you mobilize lying down, standing up, check there's still something there, then you might need to load and mobilize. So these are the traffic light guide, and this are your options to progress and or regress your loads. High reps, sustained. Now, if you're still yellow, and you just do the opposite of what you want to do. And you'll be surprised. You'll be surprised that when you do opposite, for example, external rotation, it's a controversy. But if you have a right-sided lower back pain, and then you mobilize right side and it doesn't do anything, mobilize the left and you'll be surprised. Okay, I'm out of time, but now all this is my son doing exercises. This is 4 years ago. Complement your mobilization with active exercises. Okay, active. These are active exercises. 3 things to remember real quick. Get your symptomatic mechanical baseline, range of motion, muscle strength, and neuro. Neuro is very powerful. So if you could change reflexes with mobilization, it does happen. I assure you. So check your baseline, whether it is range of motion, muscle strength, before and after therapy. It will change. Just learn from it. Check your options. Okay. Promote and range. That's where the magic happens, not Disney World. End range movements and mobilization is where the magic happens. I don't know who said that. I learned that, and I'm sharing it with you. If it's acute, mid-range, and traction. All right, 2 things to consider, right? Complement your manual physical therapy with exercise and educate your patients. All right, educate, self-manage mechanics and posture. One thing to always practice again, enjoy your patients. They will be your best teachers. Learn from your experiences, whether it is red light in your mobilizations, then you have to learn from it, make up for it on the next visit or on that same visit, even if you have to spend more than 8 minutes. Okay, so things that I'm into, I'm teaching a course in Delaware in December. It's a fundraiser for the Philippines. If you can make it, please come. I'll share it with you. I'm out of time. I'm speaking at the Asian Conference, Manipulative Physical Therapy in the Philippines in Cebu. This is a project of PAYOMP. It's very good. We're bringing home manual physical therapy education in the Philippines. I'm very involved with PAYOMP for the ones in the Philippines here. Okay. I'm sorry I rushed there. If you have any questions, feel free to ask now or email me. These are my things where you
Yeah,
could.
social media.
Yes, that's what it is.
Yeah. So Dr. George, congratulations and you're amazing. I met some of your patients when I am in acute care and you're one of the best in Milford. They're talking about yeah and said, oh, I know Dr. George. We worked together before. And then also I believe that really education is the key and you really educate your patients and I see the value there. So congratulations for bringing that.
Thank you.
Mm-hmm. Yeah.
Any questions real quick or not?
I saw a question here, Doc.
Yes.
Let me see because I'll go backward because the latest one is when you show the traffic light, it says there, what if the patient cannot really say like I can tell if it improves or not? I think that's pretty much the question there.
Okay. So it depends. I don't know how to unshare first. Stop sharing. And then we'll go back. So it depends on what your baselines are. Now, it's great if you have baselines. It's great for me. It's great if the patient is currently in pain when I see him because I have baseline right away. I'm gonna chase that pain away that session. Now, if they don't come in pain, and I have this all the time too, they don't come in pain. I only have pain when I sit for 2 hours or long car ride to New York or wherever. Now, you have to do mechanical baselines and patient baselines. Okay, so you have to have a baseline. If they are asymptomatic, that's the hardest patients. It's like being in pain or being dizzy. I'm only dizzy at home and I'm not dizzy now. So what can you do? So so for me, it depends on what your baselines are and what your goals are. Think of what your goals are, and then check that, assess that, and treat that.
Yeah, Mary Wells has two questions in a different because there's a picture a while ago and she just asked the position, but this one is more on in the Mary Wells, do you want to ask this or I'll just read it because it different when you read it. In manual therapy, then you don't discount the intention of touch, yet body of knowledge counts on biomechanical or neurophysiology effect. Conversely, when you do manual therapy, it follows the biopsychosocial model into your practice as manual PT. So it's a question. So when I read it, it looks like a statement.
Statement, yeah.
How do you understand that, Doc?
Yeah, so it's definitely psychosocial aspect is very, very big. And that's why you check and recheck, because when you make them better right away, right in front of their eyes, their brain goes around and says, ah, this is great. It's an instant in that psychology of getting better and that buy-in from the patient, that alliance is just gonna be strong. Psychosocial is scary. Neurophysiological is great. It's scientific studies, but that's mumbo jumbo to me, because I can't prove it. But what I can prove is the psychosocial aspect.
All right. And Yasmin said, because we discussed more on manual therapy, what's your go-to manual therapy approach? Aside from the joint mob that you discussed, you showed in the pictures lots of manual therapy there, kinesio, dry needling, even
Yeah,
there's manual mob. So what's
we
your go-to, she said.
we do all those. We do joint mobilizations a lot. Again, I only do now that I have the fellowship is oddly enough, I manipulate less now than what I did before, because before I was practicing. But anyway, I'm done with practicing, so I'm more intentional now. So I do low grade mobilization. I do mobilization at passive end range, and I mobilize there. As I said, that's as powerful as mobilizing at end range is very powerful. So whatever joint it is, you mobilize at end range, and it's as powerful as higher grades. So I do that. I do soft tissue stuff. I do dry needling. I'm certified with dry needling, so we do that too. And again, listen to your patients, what they prefer, what they want. They would tell you if it's soft tissue, if they think it's soft tissue. And you have to assess and confirm that too. You know, you kind of have to use your assessment there, on what your target structures are.
Yes, thank you. There's a specific picture there a while ago, but it's on the spot. So I think more on the trust. With combined movements in the picture, you elevate the first three when the guy was leaning on your knee. So yet the trust is on the right. So maybe you can answer it later, and
Yeah.
Marie can connect with you specifically on that on the chat as well. Thank you so much, Dr. George. This is really a great point for us to learn more about manual physical therapy and the importance. And then you can please put your so we work in PT Works Delaware, so that's an outpatient, and please connect with him if you're interested about the different courses. Of course, it will be live
Yeah.
because manual phys, so it cannot be virtual. That's why education, this is the max that he can say for the manual therapy itself. So thank you, Dr. George. We appreciate you. You made
My
it
pleasure.
possible for us to learn more about manual
My pleasure.
therapy. Really. All right. Thanks, guys. Just connect with him. Just put on the chat. All right. Thank you. All right, let
Thank
me
you.
see. You're welcome. All right. And then here we have Dr. George there. That's really nice. I like manual physical therapy. And here, Dr. George, we would like to give you the certificate of appreciation, and to Dr. George Rodriguera, a physical therapist and doctor of physical therapy and a fellow, for sharing his knowledge and expertise for the Geriatric Rehab Summit 2024 this August 16, and this is our 5th annual event. And thank you so much, Dr. George. We appreciate you. All right. So guys, we will have our last speaker. So live from Australia. I hope she's ready. And then we have here. So Dr. Juliet Frisch. I hope I pronounced it right. Frischi. She will going to discuss about activator poles for walking and exercise. So live from, forgot which part of Australia it was. And she who has the activator poles or has a Nordic idea about Nordic walking. So we will learn more about it for tonight with Dr. Juliet. So Dr. Juliet is an Australian physical therapist, graduating in 1985 from the University of Queensland. She has worked over the years in many settings, from large hospitals to small community health centers, and in several clinical areas. She became interested in promoting healthy lifestyles through physical activity with her older clients, and this led her to training as a Nordic walking instructor in the early 2000s and using poles in her clinical practice. Her interest in the health benefits of walking with poles led her to do further research, firstly completing her honors degree and then her PhD in physical activity and Health at the University of Queensland, completed last 2016. She is a titled physiotherapist with the Australian Physical Therapy Association and Australia's only master trainer for urban polling. Dr. Juliet currently runs her own PT business in Brisbane, the Movement Mentor Physiotherapy, specializing in exercise for older adults. She runs several urban polling, walking, and exercise groups for her clients, and Dr. Juliet and her husband, Mr. David, enjoy traveling and hiking whenever they get a chance. Oh, and she also loves violin just for fun. Okay, thank you so much, Dr. Juliet. We have the floor now. And
Okay. Oh,
let me
okay.
see.
Hello. Oh, where am I?
All right, I can see you. We can see you.
Okay. I can share. Can I share that? Will that work?
Yes. So
Okay.
you're a co-host now, so you should be able to share, Doctor.
Share that. Okay.
Yes,
Coming in.
it's working.
Yay. Okay. I'm going
And
to
you
put
can make
to
it,
slideshow. Slideshow. Hello.
yeah.
Okay. How are we going? Is that all right?
Yes, yes. Welcome.
Okay. It's thank you for those who are attending this session, this final session, and I know some of you are up quite late, and those of you in the Philippines, as with Australia, we're just getting to the good part of our day. So it's great to be here, and it was great to listen to all those lovely presentations on geriatrics. I was really chuffed to see the little kangaroo in Dr. George's session. Most of you probably wouldn't have noticed it, but being Australian, I do notice those things, and I know that Maitland and Mackenzie both come from down under, one from New Zealand, one from Australia. So that was a lovely bit of Australiana that I noticed. The title of this presentation is Physical Activity, Exercise and Activator Poles for Older Adults. So let's get going. This is me, and I'm, as Dr. Jenny mentioned, I'm a physical therapist. In Australia, we call them physiotherapists, so I might chop and change a little bit. And I use poles in individual therapy, but also in walking and exercise groups. And I have been training other health professionals in their use. I'd like to thank Dr. Jenny for inviting me to speak to you today on a topic that I am passionate about, which is incorporating poles into older adult everyday lives in order to improve their health and well-being. And just like to mention, in the interests of transparency, that I am a consultant with Pole Walking Australia, which is a distributor of urban and activator poles in Australia, and it's operated by my long-suffering husband, David. I'd like to start with an Australian acknowledgement of country. So Dr. Jenny mentioned that I tropical latitude of Australia. I'd like to acknowledge the traditional owners of Meanjin, who are the Turrbal and Yagara people, and to pay my respects to their elders past and present.
Dr.
And I'd
Juliet,
also
we
like-
lost you a while ago. Maybe you need to repeat
hello?
the part when you begin the Brisbane picture. We lost you.
Okay. My internet's been working perfectly until about 15 minutes ago, and so I'm sorry if I'm not coming through. I'm not sure why that is. So this is an Australian acknowledgement of country, and I did live in Brisbane up until July this year, and I've just moved. This is a photo of Brisbane. The Indigenous name is Meanjin, and I'd like to acknowledge the traditional owners of Meanjin, who are the Turrbal and Yagara people, and to pay my respects to their elders past and present. I'd also like to acknowledge the traditional owners of my new place of residence, which is Launceston, Tasmania. So I now live about 2,000 kilometres south of that, and you can see it's the middle of winter here and it's quite cold, hence my gloves. And the people in Tasmania, where I live now, are the people of the Kanamaluka, those who live along Tamar River. Here are the goals. I'm going to move us a little bit. I'll put me up there. That might be best. So firstly, to understand the benefits of activated poles as a physical activity tool. So we're going to look at poles in the context of what physical activity is. Secondly, to understand the features of activated poles, which make them uniquely advantageous for older adults. And then to explain the actual technique of walking with the poles and assisting gait in older adults. And finally, to look at how the poles are used to improve physical activity modalities other than aerobic exercise, such as balance and strength. So we're going to start with physical activity and health. So this is taken from the World Health Organization's statement on physical activity in 2022. Regular physical activity is proven to help prevent and manage non-communicable diseases such as heart disease, stroke, diabetes, and several cancers. I'm going to add osteoarthritis here because there is good evidence that physical activity improves symptoms of osteoarthritis also. It also helps to prevent hypertension, maintain healthy body weight, and can improve mental health, quality of life, and well-being. So why wouldn't you exercise? We're going to look a little bit more specifically now at what physical activity is. So the broadest definition is that it is moving the body. It encompasses everything from brushing your teeth to climbing a mountain. However, what we're talking about, and most health professionals are talking about when they talk about physical activity, is exercise. And this is structured physical activity for health. So the modalities include fitness, strength, balance, and flexibility. How much physical activity is necessary for health benefits? So most countries have a similar recommendation to the US, which is at least 150 minutes of continuous activity at moderate intensity on most days of the week. So this can be split up. Most health professionals who are talking about this talk about the 30 minutes per day on 5 days of a week. But it can be broken up even further into 10-minute segments throughout the day and still provide health benefits. So on a 10-point scale where sitting is 0 and working as hard as you can is 10, moderate intensity aerobic activity is around about a 5. So you'll notice you can talk, but you can't sing. And a way to remember this is that it's walk and talk. So moderate intensity activity is walk and talk. You can also do less than that, half the amount of time at a vigorous intensity. So vigorous intensity is a 7 or 8 on this scale. And the way to remember this is that it's huffy puffy. So most older people who are using activated poles will not fit into this category. So we're dealing with moderate intensity conditions. So let's move now to the right-hand side of this slide. The other area of physical activity usually incorporated into recommendations for older adults are muscle strengthening, at least 2 days of activities that strengthen muscles per week, and activities that improve balance. So we'll talk about this later on. Now let's move to activator poles. And this is a slide that, that happens to me every time, that shows the features of activator poles. And we'll see these working as the presentation moves to the more practical side. So many people have seen hiking poles, and some of you may have seen Nordic walking poles designed specifically as a fitness tool. Activator poles are different again. They're specifically designed to assist those who have some issues with walking, endurance, especially outdoors, or movement disorders such as Parkinson's disease. So they can be used as a tool for exercises targeting balance, strength, cognitive ability, and uneven gait, as well as a walking assistance. They were developed by Mandy Shintani, who's a Canadian OT, occupational therapist, and she had a master's in gerontology. She looked at Nordic walking poles and adapted them to suit the older clinical population that therapists such as myself and healthcare workers more often see. On the left-hand side of the slide, you'll see activator poles. They look slightly different from hiking poles and Nordic walking poles. So let's start at the bottom of the poles. They have a large rubber flat-bottomed bell-shaped tip, and this allows for a nice stable contact with the ground when the pole is held vertically. The hand grips are strapless, and this is for safety purposes. It has been found that Nordic walking is a very safe activity, but the most common injury from Nordic walking poles is one known as the skier's thumb, and that results from a dislocated thumb if a fall occurs, because the hand is attached to the pole through this kind of a gloved strap. So if you don't have a strap, it removes that risk in the unlikely event of a fall. So instead of a strap then, we need something to attach the hand to the pole. And there is a shelf on the lower end of the pole that you'll see there. So this allows you to rest your hands on the pole. You don't have to grip very hard. And instead of gripping, you pushing down on the pole for stability. And that secures the pole when you're walking. And finally, the poles are adjustable so that you can, and they use a button and hold mechanism, which is makes them easier to adjust, and it's also a safer pole, so a safer hold. So the recommended weight per pole is about 90 kilograms. Most hiking and Nordic walking poles are, you can go up to 40 kilograms, which is quite good also, but this just gives you that extra bit of stability. So here is a short video of the technique. So this is walking with activator poles, and it's by Barbara Gormley from Urban Polling.
There's no sounds, Dr. Juliet.
Okay, I'll talk you through. So you put the poles are right and left-handed. You put your hands around a light grip, and the poles are held vertically. You stand tall, lift your rib cage up, and your shoulders are over your hips, so you're have a nice posture. You step forward with your right foot. The left pole is put forward at the same level as your foot, so you don't put it in front or behind. And then you just take normal steps, so it's a normal step length. The bell-shaped tip is always flat, and your poles are always held vertically. You press down on the ledge of the handles for stability as you're planting the pole, and that gives you that extra bit of stability. And she's about to walk now, and it'll show you just a little bit of walking. She's walking slightly slower there. This next video will show her walking in a slightly more what our patients would probably walk. And that's from the front. And this is probably, for an older person, this is the speed that they would probably walk. Okay. So I'm going to look at general benefits of using poles. They suit a wide range of abilities, from the very active to the quite frail with limited mobilities. We use poles for people who live at home and are very active in the community, to those in senior living communities, and also you can use them with quite frail people in residential aged care. They're quite transportable, and this is really nice, not only for therapists, but also for especially community dwelling people, because they can just put them in the car, and they're great for travel. They're quite versatile, and as a physical therapist, I quite like this because I can use them for seated exercises, for standing exercises, pre-gait, as well as walking. They give a lot of support and trunk control. And they're also seen more as an active living versus a disability sort of tool. So they look like sports gear. We're often asked, oh, are you going to do the Camino, or are you practicing for skiing, something like that. And that's really also very nice for the older age group. So I'm going to now move to 3 ways that you can use activator poles. You can use them for walking, for exercises outdoors, and for exercises indoors. These exercises can be done individually, but it's lovely to do them in a group setting. And we have heard a little bit about fun, having fun and enjoyment, and that's always much easier to do when you're in a group. Most of my work has been done with people and poles in groups. So here is walking. We're going to look at walking with poles. This is where people can get that lovely 30 minutes a day of continuous, moderate intensity physical activity. Don't forget that an older person who is not very fit can get to moderate intensity, that's that walk and talk level, at a slower pace than most of us, or most people under the age of 65 would need. Muscular endurance. For many of our older clients, this muscular endurance, staying on their feet for a good length of time, is as relevant as fitness. And we did hear earlier about the problems with sarcopenia, and the fact that when your muscles are decreased, you get more stress on your joints. So if you can get that endurance, you improve that muscular strength. So people who can't, people who are older do less than they used to. They sit more. They have some maybe minor balance issues, stiffness issues that prevent them being confident when walking. So to walk continuously for a half an hour to an hour at a stretch, it's great for getting those functional leg muscles working for longer. And then they can keep up with regular activities like cooking, like housework and yard work. Posture, especially trunk control. And I often find, especially with older women, they get this kyphosed posture, and it's really nice for getting you up and getting those postural muscles working. And energy levels, this is about preventing fatigue. So regular moderate intensity exercise may assist in improving energy levels. Another source of energy is vitamin D, and you get vitamin D when you are in the sunshine. the process of converting vitamin D to energy becomes less efficient as you age. So being able to walk outdoors in the sunshine safely, it's an excellent way to get your vitamin D. A bonus is that your morning sun helps to regulate your sleep better. So if you have a morning walk, even better. And finally, psychosocial benefits. Never discount psychosocial benefits. A lot of older adults live alone, and urban polling in a group or activator walking in a group can be done by older and younger walkers together. If you do a morning walk, you can have a cup of coffee afterwards, or breakfast, and that's often the most rewarding part of the walk. If people aren't enjoying what they're doing, they stop doing it. And this is our a senior group that I started walking with. I got a group together of senior women, and this is us walking along the banks of the Brisbane River and getting our dose of morning sunshine. So we move now to the other half of the equation. Are you still hearing me? I'm not quite sure. I think you are. Would that be correct?
Yes, we can still hear you.
Thank you. Okay, so we move now to the other half of the physical activity equation, which is looking at strength, balance, coordination. Now, this is done best through exercise rather than walking. So you can target specific elements of your physical activity. Let's start with outdoor exercise groups. This is our flagship exercise class, which has been going strong for more than 4 years now. I ran this until I moved with my colleague, Dr. Denise Brooks. So she is a sports and exercise scientist. And the group, all bar one, are over 80, and they have various issues like spinal stenosis. A couple of women have rods in their backs. We've had people with strokes, knee replacements, visual disturbances. We still have a woman with who's had a shoulder replacement. Lots of arthritis, stiffness issues, those general things that happen when you become older. Our aim is to provide a safe and enjoyable outdoor exercise class for community dwelling adults that provides holistic physical exercise and social support. So in other terms, we want to assist people to get healthy physically and mentally while enjoying themselves and being with others. These are some examples of exercises that can be done with poles outdoors. Now, most of these exercises are very difficult to do without support. So having poles gives you a whole new gamut, a whole new range of ways to do your exercises. So this is us on the grass. In summer, working in a grass or a parked area is great. In summer, it's cooler. This is subtropical temperatures, so it's much easier to do on the grass. People have to adapt to wind, to light quality. You can see there the shadows, so that can provide an extra challenge for people, and more uneven surfaces. So that's a real life situation that they might come across. Here we're doing on the left-hand side some simple squats for quadriceps strength. So we're specifically targeting those large muscles that you use when you're standing to sitting, sitting to standing, and stepping up, walking up hills, those kind of things. And the second one is looking at rotation of the trunk. The picture on the left-hand side, we do a lot of supporting exercises on one leg because you need to support yourself solidly on a single leg when you're walking, stepping up, climbing stairs, and you want to get that pelvic and lateral hip support. So this one's probably where what we're doing is lifting the foot forwards, middle, sideways, middle, backwards, middle, and staying on that supporting leg for a good amount of time. The one on the right is an example of an upper limb exercise. So doing repeated push-ups, push-outs, kayaking, circles, spirals. Holding the arms up is an important activity for people to when they need to reach up to get into cupboards, hang the washing out. And I've seen a couple of people now who have fallen because they haven't had balance while they're hanging their washing out. So it requires strength, not only in the upper limbs, but also the trunk and good balance. So we're moving now to a combined exercise. So this is great for balance and for strength. So they're both important for walking, going up on your toes, back down to your heels. Most people can't do this with support, and so if you want to strengthen calf muscles or get that toe lift, which you need when you're walking, and you push down on the shelf of the pole, it creates a stable but challenge. It does give you a challenge. You do have to use your own balance strategies and mechanisms. And finally, this is stretching. We always finish with a stretch or a cool down, as most exercise classes do. This is us stretching calf muscles. You can also stretch hamstring muscles, adductor muscles. We do range of motion for upper limbs. You can even do resting your hands on the pole, and we can do some breath exercises also. The one exercise that I haven't actually done with my people is quadriceps stretches, because most people of this age can't actually get their feet up enough to do a quadriceps stretch. So moving to brain training, we do quite a few brain games to improve memory, speed, executive functioning activities such as dual tasking, and we heard a little bit about those earlier in the session. These things do have real-world applications, for example, walking and talking, and it's actually, as you get older, it does get more difficult to walk and talk together. And how many people do we see who, when we're walking along with them, they stop if they want to talk because they're not quite at that walk and talk together level. So this gets you practicing two things. You're also keeping an eye out for danger while you're moving quickly to avoid a sudden or moving obstacle like dogs or children, and also new learning. Here we're getting people to step and lift the opposite pole at the same time. Not an easy activity, and you can make it more difficult by doing those head turning movements that we learned about in the vestibular talk that we had earlier. So the instructions that we would give for this are step left, lift your right pole, and then bring it back again to the center. If you want to add a head movement, you go step left, lift right. Now look at the top of your right pole. Now come back to the middle. So you're doing a lot of things together, and that's challenging your balance, it's challenging your concentration, your learning, and coordination as well. Other brain training exercises we do are the clock exercise. So many of the physical therapists that here would understand that. So we step to different hours on an imaginary clock face. We can add colors to that. So I could say, if I say blue, you're stepping forward with your right leg. If I say red, stepping forward with your left. If I say yellow, you're stepping backwards with your right. If I say purple, you're stepping backwards with your left. And then we just say red, yellow, green, or whatever color. This is actually quite difficult for me as well as my clients. We can do Mexican pole waves. So we start passing the wave along, tap left, tap right, next person, and then it goes around the circle. We can change direction, we can speed up. So all these things are really good for getting speed training happening and concentration also. Okay, so let's move to indoor exercise groups. Generally, I do this with lower level clients. So those outdoor exercise groups that you saw, people usually come a half an hour earlier and they walk, and then we do 3/4 of an hour of exercises. So they have to be on their feet for an hour to at least an hour. Indoor exercise groups, you don't have to do that. So lower level clients might require a more controlled environment for safety, and they may not be able to walk for a long length of time. Everything here is flat. There's good, even lighting. You don't have to worry about the weather. And I can keep a close eye on participants and assist those who require it. Some of these exercises can be done either in sitting or in standing, whatever is best. Functional activities, they're great to do in this environment. Freestanding, like what this class is doing, is leaning forward before they stand up. So we're practicing lean forward, now come back. Now again, lean forward, now come back. So we can do that. We can do sitting to standing using pole support, learning to step, shifting your weight. All these tasks are made easier with the support of poles. So a few photos now of our indoor exercise groups. Here we are walking on a wide, long veranda, and this is your muscular endurance that I mentioned earlier. So we usually start our classes. I start with some walking, 5 to 10 minutes. Maybe in the middle of the class, I'll do another 5 minutes or so of walking. This is lifting the poles out and in. Getting people to move to their limits safely is very easy with poles in sitting. And I actually really like this left-hand photo, because everybody in this photo you can see sitting really tall and upright, except for the lady on the far left who was just observing this particular session. So she didn't have poles. Or everybody else is nice and tall and upright, and they're using their poles to get that upper back and trunk stability. On the right-hand side, we're doing very similar exercise to what you can do outside in standing, and that's repeated out and in with the poles. And here's some examples of some seated exercises. Reaching down to the floor is a great functional exercise, tying your shoelaces, picking things up from the floor. And I like marching with poles because it does stop people from leaning back on their chair and gives their posture a workout. When exercising in sitting, we do lower the poles by about 10 centimeters, 6 inches or so. And that keeps them at a comfortable height. Because I am going to probably, in this particular series of exercises, do standing, sitting, standing, sitting, rather than keep moving the poles, I just get people to put their hands underneath the hand grips, and that gets you down to a more comfortable height. Where are we? Now, this is us in standing. You can make this easier by just doing your lower limb. So this is then an easier cognitive exercise as well as balance-wise. So you push on the shelf for support. So you'll see the lady in the white long sleeve t-shirt on the right-hand side. She's keeping her poles firmly on the ground, and she will just be marching on the spot. Whereas the lady in the green t-shirt on the left, you can see that she has much more balance, coordination, and it'll be a much harder exercise to do cognitively, lifting right pole and left leg. And here are some examples of standing exercises. These are functional exercises, gait exercises, stepping forwards, stepping sideways, and repeated tapping out. So stepping forwards, where it's good to get that pattern of hip extension. And a lot of people will just wobble side to side, but we want to get that hip extension, get those hip extensors working when we walk. And the repeated tapping is similar to what you saw in the outdoor exercise group. So that is supporting yourself on one leg while tapping out with the other. So to finish this presentation, I'd like to just go through a couple of clinical conditions that we see more often in older adults, and how we can use poles in these clinical conditions. So I'm going to start with Parkinson's disease. If you look at the signs and symptoms of Parkinson's disease, the picture you get with most of it is this lessening of movement. So everything shrinks down, smaller steps, no arm swing, kyphosed or scoliotic back. And so things like big steps, swinging the arms, standing tall, all become challenging for the patient. So when we're looking at physical therapy modalities for this, we're aiming to increase these elements. So to practice that safely may require support. Using poles makes this support a bit more dynamic, so that you require some balance, and you can also move a bit more dynamically and change direction easier than if you've just got a fixed support. So standard clinical treatments that you can add poles to include things like large amplitude movements, range of motion. You can use the poles for that. Upright support. It assists with improving your gait speed and stride length. Gait pattern also. Repeatedly, I find in a lot of different clinical conditions, it makes you more symmetrical. So you get this much more even gait. Coordination, left versus right, upper limb versus lower limb. And endurance and strength. If people feel more confident and they are safer in walking, they will walk for longer. And it also makes exercises less abstract. So lift your pole, look at your pole, rather than look to the right or turn your head. So let's move to stroke rehab. This doesn't have sound, and this is a very short clip of hemiplegia and the use of poles with a lady named Jennifer, who has left-sided hemiplegia. So the issues that face hemiplegia can include things such as asymmetry, lack use of the affected side, and often that leads to increasing neglect over the months and years that follow. You get poor gait mechanics. You can get this kind of shuffling gait where you don't get a good heel strike. So it's a very short clip. And so I find the best way to look at it is, I'm going to play it twice. And the first time, if we look at what's going on the left-hand side of the screen, and the second time we look at what's going on the right-hand side of the screen. I'll just explain first things to watch for, so you have a better idea. because as I said, it is a very short clip. So you'll notice a couple of things when she's just using her stick. She has no arm swing at all. She's heavily dependent on that right-hand side, and her weight has shifted to that right-hand side. The other thing that you will notice is that her head is pretty much fixed, turned to the right. So we're going to have a look at that left-hand side of the video first. So you'll see that uneven gait, that fixed head to the right, and the lack of arm swing. If you look at her right now, you will see that her eyes are turned to the left, but her head is still fixed to the right. So she can't actually, she's not able to move her head to look to the left while she's walking. So let's have a look at her using the activator poles now. So she gets to use her arm, her heel strikes, and she can actually move her head. So if you look at her left foot now, you'll notice she actually has a heel strike, which is very encouraging to see. Okay, so finally, I'm going to look at hip and knee replacement surgery. So generally, hip and knee replacements require a post-op regime of 6 weeks with crutches or a walker, or a combination. So sometimes they start with a walker, they move on to crutches. And that's very important. Activator poles will not give you that amount of support. So it's very important that you start your rehab with your crutches or your walker. However, after this initial 6 weeks phase, they will say wean off is tolerated, and it's sometimes very useful to have poles in the rehabilitation phase. So poles can provide a decreased loading not only with your upper limbs, but not only with your affected limb, but with your unaffected limb as well. And again, you get a nice upright posture, quite good for weight management. I want to just qualify that by saying exercising as health professionals, we probably know that exercising once, twice a week is not going to do much for your weight management, but I have seen some good results with people who consistently exercise with poles every day in managing weight. You also get improved general health, walking tolerance, and a normalized gait pattern, which is really important when you've had one leg has had major surgery on it. So this concludes my presentation. Thank you very much for all your attention. I hope this has given you some food for thought when it comes to exercise and being creative with your exercises. And do we have time for questions? I'll just put on, for information, that if you require information for about urban polling, research, products, courses, Lisa Limper at Urban Polling would be the person to connect with. So, but thank you all very much for your attention.
Yes, thank you so much, Dr. Juliet. Yes, I will going to put Lisa's information for more further questions. And we have many webinars, free webinars, guys, if you subscribe in their newsletter, so that you're able to follow whatever new things or updates they have. So they are really very good in making free webinars for patients, clients, and of course, clinicians, you know. Thank you, Dr. Juliet. Kindly put your email on the chat as well. And guys, do you have any question for Dr. Juliet? So Ken said that it's just sad that not lots of people in US is using the activator for pole He is. Dr. Ken loves hiking, and he likes the rubber tip that you have. Yes. So I told that. All right. So Dr. Juliet, are you still here?
Yes. Sorry, are
Okay.
you not seeing me?
Yeah, that's okay.
I'm just
So
putting.
let me see. All right. So how to be a qualified practitioner of urban pollings in Philippines? Do we have Asian for the master training? I know we have those courses. Can we do it online and they can do the urban polling? I remember we had urban polling training at one point, and we delivered the urban polling in US that time. I'm not sure if we're able to do it in Asia. Are you aware of those, Dr. Juliet?
Um, I do know that urban polling courses are online now. So if you email urban polling, Lisa Limper, as I mentioned earlier, she would be able to direct you um, to online urban polling courses that urban polling runs, and they do urban polling and activator course together. Urban polling is the more active type of use of polls, which I did not go into in this presentation.
Mm-hmm. Okay. We cannot see you, Dr. Juliet. We can only see your
Oh,
slides. When
oh,
you're talking, there's no camera.
where am I? I
Yeah,
don't know.
I
I'm
just
not
want
quite
to
sure how to
highlight you there. And I can still see your slides.
try that.
Yes. And then you can stop sharing your slides if you're done, but I would love to highlight you for your um person. Yeah, Donna did one
Is,
online training, so that's good. Yeah, you can stop sharing so that they can see you during the questions if you would love. Yeah, here.
is that better?
Yes, now we can see you fully. And then, so they just want love to thank you for sharing your activator poll with us. And she's based in California. That's Marie. And also, Donna, I can't remember. Where are you based, Donna? She did an online training. What state are you from? She did, I'm not sure. Indiana. I know it's I. So she's from, I thought Illinois. Indiana. All right. Any closing remarks, Dr. Juliet? We appreciate you.
No, thank you very much for having me on.
Yes. And kindly put Lisa Limper at Urban Polling, but in their emails, definitely I will put Lisa Limper email. That way they can ask some questions, any other free webinars, and the way to sign the newsletter, I will going to write it there too. Yes, hi Kurt. Yeah.
If I could just mention, there are a lot of free webinars on that, and they're always adding. They usually have a monthly webinar, so they're always adding to their education. They're very interested in education and a lot of free education for clinicians.
It's true. I always receive the newsletter because I enrolled and subscribed. So definitely, guys, I will check on how to do that, and then I will put on the handouts and the recording of this event. So you will have lots of resources. It will be automatic once you subscribe, and you will know the days, the upcoming events. And yes, Dr. Kurt was trained also in activator pose, and he's from Michigan. Yeah, we have many courses here, and I even met Mandy Shintani before when I first heard about activator polls, and she did some training.
Mm.
So thank you so much, Dr. Julia.
There are definitely live courses in the US and Canada, and then there is also the online training. So
Yes. And I also put on the link, the Clock Yourself app. I believe that's the one you're talking about, the
that's
clock
the
and then
one.
the simple
Meg
colors.
Lowry.
Yeah, Meg
Mm.
Laurie, she's an Australian physical therapist. So I keep saying to my patients, it says yeller. I said, this is from Australia. That's why they keep smiling every time they hear because it's a yellow, green, blue, and red. All the colors are the same accent with the US. And then every time with the yellow, it says yeller. And then they keep saying a
Yellow.
nice comment. Yeah. That's why. So thank you once again, Dr. Juliet. We appreciate you.
Thank
And
you.
thank you so much. Let me see and share my screen. All right. Definitely, and you're our closing speaker. We appreciate you and thank you. All right, let me see here. Thank you so much, Dr. Juliet. And as a physiotherapist based in Queensland, Australia. Thank you for sharing your knowledge and expertise for us for the Geriatric Rehab Summit 2024 fifth annual event today, August 16, here in Delaware, USA. Thank you, Dr. Juliet, and we would love to connect with you definitely. And if you have any other questions, guys, the emails will be available and you can definitely connect with Dr. Juliet, all right? So we would love to thank Activator Poll. Of course, also they are one of the gold sponsor, and Urban Polling is proud to be an award-winning 100% women-owned, operated Canadian company. So Activator Poll, and that's the one we just talked about right now. So at least we see how it looks like, and there is also a rubber tip, looks like a boot, you know, whenever, and they have these different kinds of rubber tip. It depends on the weather. So this will really be very awesome. We have one training as well with Joy Cochran last year to improve the core. You see all the benefits and the musculoskeletal, Parkinson's disease, musculoskeletal cases, and also neuro patients will definitely benefits with our activator pulse. And then let's say thank you to our other sponsors. So would love to thank you and would love to share to you. As you are aware, I am one of the board member and treasurer of the Future Foundation. Some of our board members are here with us. They are watching. Shout out to Dr. Rose. Dr. Ellie, our president, was here as well today. And we have Dr. Donna Grace Hardulin. She's the one I'm asking where is she from, and she's from Indiana. Dr. Frecci, I believe she's from Colorado. And we are all here supporting all our geriatric rehab summit, and also would love you to learn more about us, guys. And we have a Facebook group as well to learn more. What are we doing? We are a nonprofit that channels the expertise and dedication of Filipino physical therapists globally to uplift the profession and health outcomes for communities both near and far. Originally, it's only from our alma mater. I'm from FEU Nicanor Reyes. It is based in Philippines. And then we offer now the leadership and membership to other schools. Imagine our president is from a different school. So we would love to learn more, you guys learn more about it. And our mission, Future Foundation, is a nonprofit organization that fosters, they're almost the same. We would love to learn, to share it with you. All right. And then what else we have? And American Institute of Balance, they're always supporting us, and they have a wonderful training for vestibular rehab. And this is based in Florida. Dr. Richard Gans always supporting us. And then they have discussed more, lots of every geriatric rehab summit vestibular training. And we have Dr. Kathy as well before. So they are internationally recognized as the proven leader in the evaluation and treatment of vestibular and equilibrium science and concussion management. I remember Dr. Frecci, that was July. She attended the training in AIB at one point. That's why some of our speakers are not available today. So they have lots of training. And then, thank you guys. So we would love to share it with you, and we will have another day 2. The day 2 will be tomorrow, of course. And thank you so much with our other sponsors who supported us. We have PopTalk, and then with Dr. David Newman, LSVT Big, with Laura Gusay, Ludofit with Mark Evin. I'm imagining the activator poles doing those Ludofit, like the kayaking, you know, you can use that at the same time. And then Hello Note, one of our EMR, they're always supporting us. Once a year, we have only the Geriatric Rehab Summit. They are always with us. Just want to shout out Age Wiser. Age Wiser is innovated by one of our colleagues, Swati Balantrapu. She's based in California. Check out, guys. We will give you the link. And this is an amazing app. There is an AI and the name is Jen. You know, Alexa, and then, you know, hey Google, something like that. The AI of the Age Wiser is named Jen. So connect and check out how does it work. This is definitely wonderful for our aging of the adults. All right. And activator pulse, of course, and the LIV Maradigm is the low intensity vibration. Optimist Piri. So these are some of our amazing sponsors that were able to help us bring this wonderful summit to our students, and lots of you being making it affordable and free. All right, thank you. And here will be our speakers for tomorrow. So good luck, and you can rest now. It's still early in Philippines, but you will be 8 o'clock p.m. on your time, and it will be 8 o'clock early morning on our time. So we will have you tomorrow, guys. We will talk about pain science with Dr. Ken. Dr. Brunda will talk about geriatric clinical specialization. She will talk about the NPTE. I think she will not talk about the NPTE, but she will focus more on geriatric clinical specialization. But they are the one from the NPTE Final Frontier. Dr. Net is here. She will talk about pelvic health. LSVT Big Laura Gusay and Dr. Frank about osteoporosis management. He is one of the certified in osteoporosis management. Neuropathy. Just one word, guys, neuropathy, neuropathy. And we have almost like 3 speakers to discuss that. And we will have 3 speakers for almost like 2 hours just to learn more about neuropathy. So if you want to learn about entrepreneur, your mindset to improve, we have Dr. David Bailiff and Kevin DeGroot. They are the coaches of Uncaged Clinician. And we have Dr. from St. Luke's, Dr. Jackie, and she's the president of the Dementia in Philippines, International Dementia Care. She will talk about multimodal approach. So we have lymphedema management too. If you want to learn more lymphedema mix with Dr. Anna and Oscar Pozzoli, we will have some updates about that. All right. And none other than our keynote speaker will share about, he's one of the speaker of the neuropathy. So if you want to learn more about neuro, that's a good to go. One of the key mentor, Dr. Morris. All right. Okay, guys, good night. And thank you so much. So I really enjoyed and appreciate you. All right, let me see all these comments. When I'm talking, I cannot see all those things. Thank you too. Thank you so much, guys. Yes, yes. And then if you have any questions, this is what will happen. We will send all the recordings. We will put their resources, their emails. So let's say me, I always have questions later. And then now that I will see the emails of the speakers, definitely I will ask there, you know. All right. You are welcome, guys. Good night. Okay, see you tomorrow. Bye for now. I will stop the recording so at least we save those spaces, you know. But definitely feel free to stay here if you have questions too. And stop.